Welcome to the deep dive. Today we're really getting into your source material specifically, these pediatric revision notes on cystic fibrosis.
Mm,
Think of this as your personal shortcut. We're pulling out those absolutely essential nuggets you need for revision.
exactly. The goal is simple. Unpack these notes, find the high-yield stuff, and help you feel properly clued up and ready on CF.
Clarity and recall, that's the name of the
I've
game.
got it.
Okay, let's get into it then. Starting right at the beginning, the absolute basics in your notes. What is cystic fibrosis, fundamentally?
Okay, so at its heart, cystic fibrosis, or CF, it's a genetic disorder. It affects multiple systems, but, the big ones are the lungs and the digestive system. Others too, but those are key.
Right, and the core problem, the thing that connects everything according to these notes.
It's that thick, sticky mucus.
Ah, okay.
Yeah, that's the central villain, really. This mucus physically blocks things up airways, ducts in the pancreas, liver. It causes obstruction, things can't flow properly, organs don't work right.
And this all comes down to genetics. Autosomal recessive, is that right? A specific gene defect?
Spot on, autosomal recessive. So you need to inherit a faulty copy from both parents. The gene is CFTR.
CFTR.
Yeah, and the notes say it codes for a CAMMP-regulated chloride channel protein. The crucial bit is that a defect here messes up how ions in water move across cell membranes.
Right, so that faulty ion and water movement, that's what makes the secretions thick and sticky.
Precisely. Instead of being nicely hydrated, they get dehydrated. And your notes mention, interestingly, there are over 2,000 different mutations in this CFTR gene.
Wow, okay. That explains why it can look so different in different people then.
It really does. It leads to that spectrum of severity.
Yeah.
But a really high yield point from your notes, the one to absolutely remember for exams.
Go on.
The most common mutation, particularly in Caucasians, delta F508, DF508.
DF508. Got it. If you remember that one.
Exactly.
So we know it's the CFTR gene defect. How does that defect actually happen? Let's just crystallize the etiology from the notes.
Well, it's inherited, right? These genetic mutations in the CFTR gene. Like we said, faulty gene, faulty protein, messed up ion transport, thick mucus.
Simple chain reaction.
Pretty much. And the notes specifically put that common one, delta F508, on chromosome 7 and say it's responsible for about, 80% of cases in the UK?
80% in the UK.
Hmm.
Okay. Now, something else jumped out from the notes here, specific bugs, organisms that just love this CF environment. That seems clinically vital.
Oh, absolutely vital. That sticky mucus in the airways, it's like a perfect trap and breeding ground for certain bacteria and fungi.
So which ones are listed?
The notes highlight Staphylococcus aureus, Pseudomonas aeruginosa, that one's really notorious in CF Burkholderia cepacia, and Aspergillus, which is a fungus.
Knowing those seems crucial for management down the line.
Definitely. It dictates a lot of the treatment, especially antibiotics.
Okay, let's shift to risk factors. According to the notes, who's most at risk?
The main one, the primary risk factor listed explicitly, is family history of CF.
Makes sense. Linking back to that autosomal recessive inheritance, both parents need to carry a mutation.
Right. The notes also mention it's more common in certain ethnic groups, Caucasians and Ashkenazi Jews.
But it's interesting, isn't it, that family history is flagged as the only risk factor listed here.
Yeah.
Really underscores its importance.
Yeah, it does. For risk, that's the big one.
Right. Let's get into the mechanism, the pathophysiology. This is where it gets really interesting, I think. How does that single gene defect cascade into all these problems? The notes lay out the steps.
Yeah, they do it quite nicely. So CFTR mutation leads to the faulty protein. This protein should move chloride ions out of the cell and regulate sodium channels. But when it's faulty, you get less chloride and water moving out and actually more sodium moving in, especially in the airways.
Okay, so less water going out, more salt coming in.
Which means the fluid layer on the surface, the one that keeps mucus thin, gets dehydrated. The water gets pulled into the cells instead of staying out to hydrate the mucus.
Ah, I see. So it's not just more mucus, it's that the mucus itself becomes thick and dehydrated because the water balance is wrong.
Exactly that. And because this CFTR protein is in lots of different epithelial tissues, the same basic problem causes issues everywhere.
Right, so the notes connect this to the organs.
Yeah. Airways, obstruction, can't clear stuff, infections, inflammation, pancreas enzymes get stuck, damage the tissue, liver, bile ducts blocked, GI tract, blockages from viscous secretions, sweat glands. Can't reabsorb salt properly, hence the salty sweat.
Wow, one mechanism, multi-system effects. And that airway environment, perfect for those bugs we mentioned earlier.
Precisely. The thick mucus traps bacteria, they colonize, cause chronic infections. It's a major, major part of the disease.
Okay, so if someone comes in and you're thinking maybe CF, but maybe something else, what are the differential diagnoses listed in the notes? What else could it be?
Good question. The notes give a list of conditions that might overlap symptom-wise, especially respiratory or GI stuff. Things like primary ciliary dyskinesia, PCD, that also affects mucus clearance, chronic bronchitis, bronchiectasis, although CF causes bronchiectasis, other things can too. Asthma, obviously. Certain immune deficiencies, other causes of pancreatic insufficiency. Yeah. And even GERD, gastroesophageal reflux disease.
So ruling out the lookalikes.
Essentially, yes.
Let's talk numbers then. Epidemiology. How common is CF, according to the notes, especially here in the UK?
The sources give us some clear figures. Incidence in the UK is around 1 in 2,500 to 3,000 live births.
Okay.
It affects both sexes, but it's much more common in people of Caucasian descent. The notes call it the most common inherited disease in white populations.
And the prevalence figure?
Around 1 in 3,000 to 4,000 newborns among Caucasians.
And that carrier frequency stat always gets me 1 in 25 people carrying a CFTR mutation. That seems quite high.
It is surprisingly high, yeah. Explains why it's the most common serious recessive condition in that population. The notes also give a specific UK registry number, 10,509 cases back in 2018. Gives you a sense of scale.
And again, family history is the only listed risk factor.
Yep, reinforcing that point.
All right, let's paint the picture. Clinical features. What does CF actually look like when you see a patient? The notes have a big list. How can we break it down?
Okay, the notes group them pretty well. First up, respiratory symptoms. These are often front and center.
Like the cough.
Yeah, a persistent cough, often productive, bringing up thick sputum. Recurrent chest infections, pneumonia, bronchitis. Over time, progressive breathing difficulty. You might hear wheezing or crackles on listening to the chest.
And the notes mention upper lobes specifically.
Yes, that's a good point. Often more prominent in the upper lobes later on. And on lung function tests, you see reduced FEV1 showing airflow obstruction.
Okay, respiratory, then digestive, stemming from the pancreas issues.
Right, malabsorption is key. That leads to steatorrhea, those classic fatty, bulky, difficult to flush stools.
Which causes failure to thrive in kids.
Exactly. Other digestive things listed. Acute pancreatitis, sometimes rectal prolapse.
And then there's this other features list, some really specific high-yield points here.
Definitely. Nasal polyps and the notes really hammer this home. Nasal polyps in a child. Think CF. Almost always due to CF in kids.
That's a massive red flag then.
Huge. Other things, liver disease, short stature, CF-related diabetes, delayed puberty, male infertility.
Due to the absent vas deferens.
Often, yes. Congenital bilateral absence of the vas deferens. Female subfertility can happen too. And that classic sign, salty tasting skin.
The salty baby kiss.
That's the one.
The notes also break down presentation by age, which seems useful.
Yeah, that's helpful. Neonates, about 20% present with meconium ileus. That's bowel obstruction from the first stool. Less often, prolonged jaundice.
Infants and children.
More likely the recurrent chest infections, chronic cough, sputum.
And older patients, adolescents, adults.
Can present looking a bit like atypical asthma or with established bronchiectasis, chronic sinus problems, or, as we said, male infertility.
Okay, and physical signs on examination.
Finger clubbing is a big one. Chronic lack of oxygen. That productive cough, maybe with purulent sputum, crackles and wheezes, again, listen to those upper lobes, and the spirometry showing obstruction. Oh, and an important point from the notes. Babies picked up on newborn screening might not have any symptoms at first.
Right, the screening finds them before they get obviously sick.
Yeah.
Okay, so we have the picture. How do we confirm it?
Yeah.
Investigations.
The absolute cornerstone for diagnosis, the gold standard according to these notes, is the sweat test.
And the numbers. Need to know the numbers.
Definitely. Chloride concentration over 60 millimole, that's the magic number, and crucially confirmed on 2 separate occasions.
Over 60 times 2.
Got it. Then molecular genetic testing, obviously, to find the specific CFTR mutations.
Makes sense.
Imaging. Important too. Sinus X-rays, or CTs, the notes say sinus opacification is present in almost all CF patients. That's a strong link.
Wow.
And chest X-ray, or CT thorax, to look for lung damage, like bronchiectasis. Lung function test spirometry, vital for monitoring, but remember the note says it's unreliable under age 6.
Okay. And identifying those bugs.
Sputum microbiology, essential for guiding antibiotic choice.
Any other tests listed?
Yeah, standard bloods. FBC, UNEs, fasting glucose for diabetes watch, LFTs for liver. And specifically, checking fat-soluble vitamin levels A, D, and E because of malabsorption, semen analysis if infertility is a question.
It's clearly a complex condition needing long-term care. How is it managed? The notes mention multidisciplinary teams.
Absolutely. It's complex, lifelong. Care in the UK is through specialized MDTs and tertiary centers. The whole aim, the notes say, is easing symptoms, preventing complications, improving quality of life. Very personalized.
What are the main management areas? Respiratory must be huge.
It is. Big focus on clearing that mucus. Daily chest physiotherapy is key. Regular sputum samples to track bugs. Antibiotics, sometimes prophylactic, often high-dose IV or nebulized for flare-ups. Nebulized meds like bronchodilators or mucolytics too, all trying to prevent worsening lung damage like bronchiectasis or respiratory failure.
What about the nasal polyps we mentioned?
Initial treatment is usually nasal steroids. If they don't work or are severe, surgery, polypectomy.
And the pancreatic insufficiency
Yeah.
affects most patients, right?
Over 85%, yeah. Diagnosed usually with stool elastase test. Management is lifelong pancreatic enzyme replacement therapy capsules taken with every meal and snack, plus supplementing those fat-soluble vitamins, A, D, E, and K.
Nutrition is vital too.
Hugely. Regular weighing, high-energy, high-protein diets are encouraged, often need nutritional supplements, sometimes even tube feeding to maintain weight.
Liver disease.
Affects up to 30%. Needs monitoring with LFTs. Sometimes a drug called ursodeoxycholic acid or UDCA is used.
And CF-related diabetes.
Very common. Increases with age. Needs regular screening, often starting in childhood. Usually requires insulin treatment.
Reproductive health.
Addressed too. Male infertility due to that obstructive azoospermia is the norm. Female fertility is generally better, but issues can arise. Genetic counseling is really important for anyone considering starting a family.
And the notes mention psychological support.
Yes, specifically highlighted as crucial. It's a huge burden, living with a chronic illness like CF.
Bone health too, osteoporosis.
Yeah, affects about a third of adults. Managed with calcium, vitamin D, sometimes bisphosphonates.
And follow-up is intense.
Very. Regular specialist visits, often twice a year recommended. Lots of routine checks. Lung function, chest x-ray, bone density scans, DXA, glucose monitoring, liver tests, vitamin D levels, sputum cultures, sometimes abdominal ultrasound. Plus keeping vaccines up to date, varicella, annual flu, pneumococcal. It's comprehensive.
Okay, given all this complexity, what's the outlook? Prognosis, the notes mentioned improvements.
Yeah, this is a really positive point in the notes. Huge improvements over the last few decades. Centralized care, aggressive treatment. Median survival jumped from 30 to 37 years in just 1 decade.
That's significant progress.
It really is. The notes give estimated survival figures now around 45 to 57 years for males, maybe slightly lower, around 40 for females.
And it mentions factors linked to worse prognosis.
Yes, being female and lower socioeconomic status are highlighted as associated with poorer outcomes, unfortunately.
Anything else on treatments improving survival?
It mentions ardinase, that's nebulized Dornase alpha, helps improve survival, particularly in those with lower lung function. And there's a hopeful mention of future therapies.
Aiming at the basic defect.
Exactly. The hope is these could potentially normalize life expectancy one day. There's a brief mention of gene therapy trials.
Liposome-based gene transfer.
That's the one. Showed some promise in improving lung function, but the notes are clear. Much more research needed there. It's not standard care yet.
Right. Okay, finally then, potential complications. What are the long-term problems listed that can arise from having CF?
The notes list the big ones, many we've touched on. Frequent lung infections leading to bronchiectasis, eventually respiratory failure, pancreatic insufficiency and resulting malnutrition,
Right.
CF-related diabetes, liver disease, potentially cirrhosis, infertility, those nasal polyps again, bone disease like osteoporosis, and other GI issues like distal intestinal obstruction syndrome. It really shows how widespread the impact is.
Wow. Okay, that really was a deep dive through those CF revision notes. From the CFTR gene right through to prognosis and complications. Covered a lot of ground.
Yeah, hopefully breaking it down like that, hitting the key mechanisms, the high-yield facts, DF508, the sweat test 60, the bugs, the red flags like nasal polyps in kids. Hopefully that makes it stick better for your revision. Understanding the why helps remember the what.
Definitely. So, think about everything we've covered. What's one final thought for you, our listener, to mull over after this?
Well, you know, the notes paint this picture of incredible progress, right? Survival jumping significantly in just a decade. And then there's that mention of future therapies aiming to fix the root cause, the basic defect. It makes you wonder,
Yeah.
How much further can we actually push this? With science constantly advancing, what does the future really hold for managing, maybe even curing CF? What could that look like for patients down the line?
A really powerful thought about medical progress. We hope this deep dive into your notes has been genuinely helpful for your revision journey. And don't forget, resources like PathMSRA.com and FreeMSRA.com could be fantastic tools as you keep preparing.
Absolutely. Keep digging into the material, keep connecting the dots.
Until next time, keep learning.